Welcome back to Clinical Hematology Reviews. Today we'll be discussing the manual spun hematocrit. While automated analyzers routinely compute red cell parameters today, the manual spun microhematocrit remains our definitive reference standard and a crucial verification tool in the clinical laboratory.
It provides an absolute physical measurement of red cell mass without relying on electronic impedance or mathematical derivation. Whenever automated counters are flagged for interference from cold agglutinations, extreme leukocytosis, or severe leukemia, this manual method resolves the discrepancy.
The fundamental principle of the spun hematocrit, or packed cell volume, is measuring the proportional volume of whole blood occupied by erythrocytes. We express this result either as a conventional percentage or as a volume fraction in liters per liter using the International System of Units.
To achieve this, whole blood in a standardized capillary tube undergoes centrifugation at approximately 5,000 revolutions per minute for 5 minutes. This gravitational force stratifies the sample into 3 density-dependent phases. At the top, you have the clear plasma, followed by a narrow middle buffy coat consisting of white blood cells and platelets, and finally, the packed red blood cell column resting at the bottom.
Setting up this procedure requires specific, standardized consumables to maintain analytical precision. We require whole blood anticoagulated with EDTA, collected in lavender-top tubes, which must be free of any microclots and processed within 4 hours of collection.
The blood is drawn into plain, non-heparinized glass or plastic-shielded capillary tubes with a uniform internal bore diameter between 1.1 and 1.2 millimeters. We also need non-absorbent critocele clay to form a dense base plug, a dedicated microhematocrit centrifuge, lint-free gauze, and a calibrated microhematocrit reader disc.
The manual technique follows a strict 6-step workflow, starting with thoroughly mixing the primary EDTA collection tube by gentle inversion. We then fill 2 identical capillary tubes approximately 2/3 to 3/4 full purely by capillary action.
Next, we wipe the exterior glass clean with lint-free gauze, taking special care not to touch the open tip and wick sample out. The dry end is pressed into the critocele block to form a 4 to 5 millimeter sealant plug.
When loading the centrifuge, there is one critical directional rule that cannot be violated. The clay-sealed ends must face outward against the perimeter rubber gasket. If loaded with the clay pointing toward the center, the high centrifugal force will immediately eject the entire blood specimen into the rotor housing.
After logging the numerical rotor slot positions for each patient, the safety lid is securely tightened down. The centrifuge is run at 5,000 revolutions per minute for 5 minutes, allowing the rotor to coast to a complete stop on its own.
Reading the separated capillary tube requires precise optical alignment on the microhematocrit reader disc. We place the spun tube into the reader groove with the sealed clay plug oriented toward the center of the disc.
First, slide the tube so the interface between the critocele clay and the packed red blood cells aligns precisely with the black 0% baseline mark. Then, rotate the reader assembly so the outer pin aligns with 100%, holding the bottom disc stationary while moving the upper disc until the curved line aligns with the top of the plasma meniscus.
The critical measurement step is aligning the curved reader line specifically with the junction between the packed red cells and the buffy coat. The white leukocyte and platelet layer must be entirely excluded from the reading to avoid false elevation. Once aligned, we read the percentage scale directly to the nearest 0.5% increment.
Quality control mandates that all patient samples are tested in duplicate to detect any random filling or sealing artifacts. The 2 capillary tubes must agree within an acceptance tolerance of plus or minus 1.0%, meaning within 1 percentage point of each other.
If tube 1 reads 42.0% and tube 2 reads 42.5%, the difference is 0.5%, which is acceptable. We average those values and report the final result in 0.1% increments, giving a reported value of 42.3%. Conversely, if the duplicates read 40.0% and 42.0%, the difference of 2.0% exceeds our tolerance. That run must be rejected entirely and repeated from fresh capillary tubes. Furthermore, Patient results can never be reported if commercial high and low controls fall outside established standard deviations. Reference intervals for hematocrit vary significantly across a patient's lifespan due to changing oxygen environments and hormonal influences. Full-term newborns exhibit physiological polycythemia driven by the relatively hypoxic in utero environment, with reference intervals ranging from 42 to 60%, or 0.42 to 0.60 liters per liter.
As neonatal oxygen saturation increases post-birth, erythropoietin secretion is downregulated and fetal red blood cells undergo normal senescence. This leads to a physiological nadir around 2 months of age, where reference values drop to between 28 and 42% before pediatric marrow production gradually increases levels back to 35 to 45% by age 12.
Following puberty, sexual dimorphism establishes distinct adult baselines. Adult males have a reference range of 42 to 52%, or 0.42 to 0.52 liters per liter, primarily driven by testosterone stimulating renal erythropoietin production.
Adult females maintain a lower baseline of 36 to 46%, or 0.36 to 0.46 liters per liter. This lower range reflects the lack of androgen-driven marrow stimulation, alongside physiological blood loss during menses.
A key physiological concept in manual hematocrit testing is the trapped plasma phenomenon. Because red cells do not pack into a solid crystalline mass, small amounts of plasma remain trapped in the interstitial spaces, making normal manual spun hematocrits roughly 2 to 3% higher than automated instrument values.
This trapped plasma artifact becomes significantly exaggerated in disorders featuring abnormal red cell morphology or rigidity, such as sickle cell anemia, hereditary spirocytosis, hypochromic anemias, and macrocytosis. These irregularly shaped cells cannot deform to pack tightly, leaving large interstitial gaps that artifactually elevate the spun result.
Technical execution can also introduce profound analytical bias. Undercentrifugation from spinning under 5 minutes or at low speeds prevents complete cellular compaction, producing a falsely elevated hematocrit. On the other hand, incomplete tube sealing allows red cells and plasma to leak out through the clay plug during the spin, causing a falsely decreased value.
Additional analytical pitfalls include incorrectly including the Buffy coat in the measurement line, which causes a falsely elevated reading. Pre-analytical clotting consumes red cells into a localized fibrin mesh, and specimen hemolysis lyses cellular membranes, both of which lead to a falsely decreased packed cell volume.
Finally, there is a critical safety warning regarding the microhematocrit centrifuge. You must never attempt to stop a spinning rotor by applying hand or glove pressure to the lid plate or center spindle.
Applying manual braking creates an abrupt deceleration force that slings the packed red cell column forward into the plasma layer, destroying the interface and causing a falsely elevated result. More importantly, it creates an immediate hazard of tube breakage, severe mechanical hand injury, and biohazardous aerosolization.
Today we covered the principles, manual techniques, reader alignment rules, physiological reference intervals, and clinical artifacts associated with spun hematocrit testing.
Thank you for joining us, and we look forward to having you with us next time.